Welcome to today's video about early signs of atherosclerosis. Your arteries might be silently narrowing right now, and you wouldn't even know it. Atherosclerosis doesn't announce itself with chest pain or breathlessness at first. Instead, it whispers through subtle signs that most people completely overlook until it's too late. What if I told you that your body has been sending warning signals for years, perhaps even decades, before a heart attack or stroke occurs? These aren't just random symptoms. They're your body's early alarm system, trying desperately to get your attention. Today we're exploring 11 early markers of atherosclerosis that can actually be detected, some through simple physical examination and others through basic medical tests. Understanding these signs could save your life or the life of someone you love. Stay with me until the end, because what you're about to learn might be the most important health information you hear this year. All right. Let's jump into the list of early signs of atherosclerosis, starting with number 1, endothelial dysfunction. Let's start with something happening at the cellular level, invisible yet incredibly significant: endothelial dysfunction. Your arteries are lined with a thin layer of specialized cells called the endothelium. This lining acts as a sophisticated control center, regulating blood flow by releasing nitric oxide and other substances that cause arteries to dilate and constrict as needed. Long before any plaque becomes visible, this endothelium begins losing its ability to function properly. When healthy, these cells respond to increased blood flow by relaxing and widening the artery. But in early atherosclerosis, this response weakens or disappears entirely. Researchers have identified endothelial dysfunction as one of the earliest measurable biomarkers of developing arterial disease. Studies published in the European Heart Journal confirm that this dysfunction precedes the development of atherosclerosis, occurring before any thickening of the arterial wall or plaque formation becomes evident. In research settings, doctors assess this using a technique called flow-mediated dilation, which measures how well the brachial artery in your arm dilates when blood flow is temporarily restricted and then restored. While this test isn't routinely performed during standard checkups, it represents a crucial concept. Your arteries show signs of trouble before any blockage develops. This dysfunction reflects the very beginning of the atherosclerotic process, a stage where lifestyle intervention could potentially reverse the damage. Think of the endothelium as your arterial health's first line of defense. And when it starts failing, warning lights are flickering on your body's dashboard before the engine actually fails. Next, sign number 2, fatty streaks in arterial walls. Now, let's discuss what happens next in your arterial walls: the formation of fatty streaks. These are the earliest structural changes of atherosclerosis. And here's what makes them particularly alarming. They can begin forming incredibly early in life, even during childhood and adolescence. Fatty streaks are accumulations of lipid-loaded foam cells that infiltrate the innermost layer of the arterial wall, called the intima. Research from the Pathobiological Determinants of Atherosclerosis in Youth study examined arteries from over 3,000 individuals aged 15 to 34 who died from external causes. They found that fatty streaks were present in the majority of young people. Studies published in the American Journal of Clinical Nutrition demonstrate that microscopic fatty streaks appear in the coronary arteries of more than half of children, aged 10 to 14 years. Under a microscope, pathologists have identified these lesions in young people, revealing that atherosclerosis often begins decades before it causes any symptoms. These fatty streaks represent the foundation upon which more dangerous plaques will eventually build. As these lesions progress, they can develop into raised fatty streaks and eventually into fibrous plaques. The intimal layer thickens, creating a measurable change in the arterial wall structure. Modern imaging techniques, particularly carotid ultrasound, can detect this thickening by measuring carotid intima-media thickness. When increased beyond normal ranges for age and sex, it indicates that the atherosclerotic process has moved beyond just cellular dysfunction. It's now physically remodeling arterial walls. Think of it as the difference between a foundation showing cracks and the foundation actually beginning to crumble. Next, sign number 3, carotid intima-media. Thickening, building on what we just discussed. carotid intima-media thickening deserves special attention because of its clinical usefulness. When you undergo a carotid ultrasound examination, technicians examine the carotid arteries in your neck, the major vessels supplying blood to your brain. This non-invasive, painless test can reveal not just thickening of the arterial wall, but also the presence of actual plaques, even small ones that aren't yet causing significant blockage. What makes this finding valuable is its predictive power. Research published in the Journal of the American Heart Association demonstrates that people with increased carotid intima-media thickness, or detectable carotid plaques, have significantly higher risk of future heart attacks and strokes compared to those with normal findings. Multiple large studies, including the Atherosclerosis Risk in Communities study and the Cardiovascular Health study, have confirmed this association. This is why carotid ultrasound has earned its place as one of the standard methods for detecting subclinical atherosclerosis, disease that's present but not yet causing symptoms. The beauty of this test lies in its accessibility and safety. There's no radiation exposure, no needles, and no contrast agents required, yet it provides a direct window into your vascular health, showing doctors actual structural changes rather than just risk factors like cholesterol numbers. Studies show that carotid plaque presence is an even more powerful predictor than thickness measurements alone. When physicians can see thickening or plaque formation in your carotid arteries, they're no longer guessing about cardiovascular risk. They're observing direct evidence of disease, transforming prevention from theoretical exercise into targeted intervention. Next, sign number 4, audible bruit. Over an artery. Here's something your doctor might detect during a routine physical examination: a bruit. This term, pronounced bruit, refers to an abnormal whooshing or swooshing sound heard through a stethoscope when listening over an artery. It's the sound of turbulent blood flow, and turbulence in your arteries usually signals trouble. When blood flows smoothly through a normal, open artery, it makes no sound that a stethoscope can detect. But when an artery becomes narrowed by atherosclerotic plaque, blood must squeeze through a tighter space, creating turbulent, audible flow. Doctors routinely listen over the carotid arteries in your neck, but bruits can also be detected over renal arteries in the abdomen or femoral arteries in the groin area. According to research published in Stat Pearls, the presence of a carotid bruit indicates underlying arterial stenosis, though its sensitivity for detecting significant narrowing is limited. Studies from Johns Hopkins Medicine and Cleveland Clinic confirm that a carotid bruit can prompt further investigation, such as ultrasound or other imaging studies, to determine the severity of stenosis. What makes a bruit particularly significant as an early sign is that it can be present even when you feel perfectly fine and have no symptoms whatsoever. Research from the Northern Manhattan study found that while bruits have relatively poor sensitivity in detecting carotid stenosis, they are strong markers of systemic atherosclerosis, with associated increased cardiovascular risk. The bruit is your artery announcing its distress in a language only a stethoscope can hear, a simple examination technique that remains clinically relevant today. Next, sign number 5, asymmetric or weak pulses. Your pulse tells a story, and when that story differs between your limbs, it's time to pay attention. Asymmetric pulses or weaker pulses in one limb compared to another can signal arterial narrowing affecting blood flow. During a thorough physical examination, your doctor should check pulses at multiple sites: the radial pulse at your wrist, the brachial pulse in your upper arm, the femoral pulse in your groin, and the dorsalis pedis and posterior tibial pulses in your feet. When atherosclerosis narrows an artery upstream, the pulse downstream becomes diminished or delayed. For example, if you have significant narrowing in the aorta or iliac arteries, the pulses in your legs might be noticeably weaker than those in your arms. Sometimes this difference is subtle and requires an experienced examiner to detect, but other times it's dramatic enough that different blood pressure readings can be measured between limbs. Medical literature from the University of Ottawa Heart Institute confirms that a significant blood pressure difference between arms can indicate narrowing of the subclavian artery on one side. These pulse findings represent mechanical evidence that blood flow is being impeded somewhere along the arterial tree. What's particularly valuable about pulse examination is its simplicity and immediacy. No equipment is needed beyond skilled hands and clinical experience. Yet this simple examination technique can reveal peripheral arterial disease that might otherwise go undetected for years, silently progressing until symptoms become unavoidable. Asymmetric pulses serve as tangible evidence that atherosclerosis is restricting blood flow to your extremities. Next, sign number 6, intermittent claudication. Now we reach intermittent claudication, which represents the transition from silent atherosclerosis to symptomatic disease in the peripheral arteries. Claudication is a distinctive pattern of pain or discomfort that occurs in muscles during exertion and resolves with rest. Most commonly, people experience it in their calves while walking, though it can also affect the thighs or buttocks, depending on where the arterial narrowing is located. The pain is typically described as cramping, aching, tiredness, or heaviness. What makes claudication characteristic is its predictability. It comes on with activity and relieves with rest, usually within just a few minutes. This pattern exists because leg muscles need more blood flow during exercise, but narrowed arteries cannot deliver enough oxygen-rich blood to meet the demand. The result is muscle ischemia, or inadequate oxygen supply, which causes pain. Once you stop walking and the muscle's oxygen demand drops, the available blood flow becomes sufficient again and the pain dissipates. According to the National Heart, Lung, and Blood Institute and Cleveland Clinic, claudication is often the first symptomatic manifestation of peripheral artery disease. Many people, especially older adults, incorrectly attribute this pain to musculoskeletal problems and delay seeking medical attention. But claudication is a serious warning sign that atherosclerosis has progressed enough to limit blood flow during periods of increased demand. Research shows that people with peripheral artery disease have significantly elevated risk of heart attack and stroke because atherosclerosis is typically a systemic disease affecting multiple arterial beds simultaneously. Next, sign number 7, erectile dysfunction. In men, here's a connection that surprises many men. Erectile dysfunction can be an early warning sign of atherosclerosis. The relationship between erectile dysfunction and cardiovascular disease is more than coincidental. It's anatomical and physiological. Achieving and maintaining an erection requires adequate blood flow through relatively small arteries that supply the penis. Because these penile arteries are smaller than the coronary arteries that supply the heart, they can become narrowed by atherosclerosis earlier, producing symptoms before heart disease becomes apparent. Additionally, the same endothelial dysfunction affecting other vessels throughout the body affects penile arteries. When the endothelium cannot properly regulate blood flow and arterial dilation, erectile function suffers. Research from the National Heart, Lung, and Blood Institute and Cleveland Clinic demonstrates that men who develop erectile dysfunction, particularly younger men without other obvious causes, have increased risk of cardiovascular events in subsequent years. This has led some physicians to view erectile dysfunction as a potential sentinel event, an early indicator that atherosclerosis is developing in the vascular system. Of course, erectile dysfunction has many potential causes, including psychological factors, hormonal issues, medications, and neurological conditions. Not every case relates to atherosclerosis. However, when erectile dysfunction occurs in the context of cardiovascular risk factors like high cholesterol, hypertension, diabetes, or smoking, the vascular connection becomes more likely and concerning. This is why men experiencing new or progressive erectile dysfunction should have a thorough cardiovascular risk assessment, not just medication for the symptom itself. Erectile dysfunction may be your body's way of warning about arterial disease. Next, sign number 8, transient vision loss. Let's discuss a particularly alarming symptom that demands immediate medical attention. Transient monocular visual loss, also known by its medical term, amaurosis fugax. This describes episodes of sudden, temporary vision loss in one eye, often described by patients as a curtain or shade descending over their vision. These episodes typically last from seconds to several minutes before vision returns to normal. What causes this frightening symptom? Usually it results from a small embolus, a piece of atherosclerotic plaque or blood clot that breaks off from a narrowed carotid artery and temporarily blocks blood flow to the retinal artery supplying the eye. Alternatively, it can result from critically reduced blood flow through a severely narrowed carotid artery. According to research from the National Heart, Lung, and Blood Institute, amaurosis fugax is essentially a transient ischemic attack affecting the eye rather than the brain. It's a stroke warning sign that should never be ignored. In some cases, an eye doctor performing careful retinal examination might actually see evidence of these emboli. Small, bright yellowish plaques visible in the retinal arterioles are called Hollenhorst plaques, named after the ophthalmologist who first described them. Studies published in journals from the American Heart Association confirm that these are cholesterol crystals that have lodged in tiny vessels of the retina after breaking off from atherosclerotic plaques upstream, typically from the carotid artery. The presence of Hollenhorst plaques is a classic ocular finding directly related to atherosclerosis and indicates significant risk for stroke and other cardiovascular events. Next, sign number 9, retinal vascular changes. Beyond the dramatic finding of Hollenhorst plaques, more subtle retinal vascular changes can also signal systemic atherosclerosis. When an eye specialist examines your retina, the light-sensitive tissue at the back of your eye, they're actually looking at the only place in the body where blood vessels can be directly visualized without invasive procedures. The retinal microvasculature serves as a remarkable window into overall vascular health. Specific patterns of retinal microvascular changes have been associated with increased cardiovascular risk. These include generalized narrowing of the retinal arterioles, increased tortuosity or twisting of vessels, and changes in the ratio between arteriolar and venular widths. While these findings are subtle and require expert interpretation, research studies have demonstrated correlations between such retinal microvascular signs and the presence of coronary artery disease or risk of future cardiovascular events. The logic behind this connection is straightforward. If small vessels in the retina show signs of damage from processes like hypertension, inflammation, and atherosclerosis, it's reasonable to suspect that small vessels throughout the body, including in the heart and brain, are similarly affected. Research published in Spanish cardiology journals has documented these associations. This is why a comprehensive eye examination isn't just about checking vision. It's also a valuable opportunity to screen for systemic vascular disease. The retinal examination provides non-invasive access to direct visualization of blood vessels, offering clues about what might be happening in vessels you cannot see deep inside your body. Your eyes truly can be windows to your cardiovascular health. Next, sign number 10, xanthomas and corneal. Arcus. Now, let's turn to visible skin and eye findings that can serve as external markers of internal lipid problems driving atherosclerosis. When cholesterol and other lipids reach abnormally high levels in the bloodstream, they don't just accumulate in arterial walls. Sometimes they deposit in more visible locations. Tendon xanthomas are firm, yellowish nodules that develop in tendons, most commonly over the Achilles tendon at the back of the ankle or over the extensor tendons on the backs of the hands. These represent collections of cholesterol-laden cells that have infiltrated the tendon tissue. Xanthelasma refers to yellowish plaques or patches that appear on the eyelids, typically near the inner corners of the eyes. While xanthelasma can occasionally occur in people with normal cholesterol levels, it's often associated with lipid abnormalities. Corneal arcus is a grayish or whitish ring that forms around the periphery of the cornea. In elderly individuals, this finding is quite common and not necessarily concerning, but when it appears in younger people, it strongly suggests an underlying lipid disorder. Research published in Global Heart and various medical journals confirms these associations. These cutaneous and ocular signs aren't manifestations of atherosclerosis itself, but rather indicators of the severe dyslipidemia that drives atherosclerotic disease. When you see someone with tendon xanthomas or prominent xanthelasma, especially if they're relatively young, you're looking at powerful red flags pointing towards substantially elevated cardiovascular risk. These visible markers should prompt comprehensive lipid testing and aggressive management of cholesterol levels to prevent progressive atherosclerosis. Next, sign number 11, elevated inflammatory biomarkers. Finally, let's discuss laboratory biomarkers that can detect atherosclerotic risk before symptoms appear. While these aren't visible signs you can see on physical examination, they're measurable indicators of the inflammatory and metabolic processes underlying atherosclerosis. High-sensitivity C-reactive protein, abbreviated as hsCRP, has emerged as one of the most clinically useful inflammatory markers. C-reactive protein is produced by the liver in response to inflammation, and elevated levels indicate systemic inflammation occurring somewhere in the body. In the context of cardiovascular health, elevated hsCRP reflects vascular inflammation associated with atherogenesis, the formation of atherosclerotic plaques. Multiple research studies published in journals from the National Institutes of Health and the American Heart Association have demonstrated that individuals with elevated hsCRP levels have increased risk of heart attacks and strokes, even when their traditional risk factors like cholesterol seem well controlled. Other biomarkers gaining attention include oxidized LDL cholesterol, various interleukins, and advanced lipoprotein testing that measures particle number and size rather than just total cholesterol levels. What makes these biomarkers valuable is their ability to identify high-risk individuals who might otherwise appear low risk based on conventional testing. For instance, someone might have acceptable total cholesterol numbers, but still harbor significant cardiovascular risk due to elevated inflammatory markers or unfavorable lipoprotein particle distribution. These laboratory tests represent the cutting edge of cardiovascular risk assessment, moving beyond simple cholesterol measurements to evaluate the complex biological processes that drive atherosclerosis at the molecular level. There you have it, 11 early signs and markers of atherosclerosis that can be detected long before a heart attack or stroke occurs. From endothelial dysfunction and fatty streaks to physical findings like bruits and weak pulses. From visual symptoms like transient blindness to laboratory biomarkers revealing inflammation, your body provides numerous warning signals if you know what to look for. The key takeaway is this: atherosclerosis is not a sudden event, but a decades-long process. And early detection creates opportunities for intervention that can change your health trajectory. If this video has given you valuable knowledge, please type "insightful" in the comments below. Your feedback truly encourages us to create more evidence-based health content. Don't forget to hit that like button, share this video with family and friends who need this information, and subscribe to stay updated on future health topics. Thank you so much for watching, and here's to your cardiovascular health.